My name is Philippe Guerin. I'm the director of the Infectious Disease Data Observatory at the University of Oxford. So, Noma is an old disease in the sense that first report in the scientific literature are from the 19th century, where it was reported in vulnerable population in Europe and as well in North America. And then with the development of the economy in those countries, Noma has almost disappeared. We have seen a resurgence of Noma during the Second World War, in particular in concentration camps, where the situation was actually mimicking very high poverty. Now, today, the majority of cases are reported in a low and middle income country. The classical region where Noma has been described and reported are sub-Saharan Africa, and in particular the Sahelian region, which is somewhere in between Senegal and Ethiopia. Now, the literature also, when we look at it, and when people have been looking for Noma in other regions, have found it. I think the problem that we have to date is that when you don't look for Noma and there is no clear mechanism of reporting of Noma, it is not captured. Healthcare providers don't really recognize the disease, and therefore it doesn't come up as a public health problem in many other regions. IDDO's contribution in the process of declaring Noma as an NTD was to conduct a systematic review of the literature, looking at all the evidence that we could find on potential etiology, risk factor associated with Noma, burden of disease, and trying to gather all this evidence and demonstrate actually the limited information that we have, the huge gaps, the heterogeneity in the way things were reporting in the literature, to try to demonstrate that further investment is badly needed. The key findings of the systematic review is first, demonstrating that actually Noma does not only happen in the Sahel region. It does happen in multiple regions, and when we have looked at the literature, we found reports of Noma in South Asia and Southeast Asia, in the southern part of Africa, in Latin America. So this is still occurring in many countries, and the distribution of Noma is much larger than what we believe initially. The second finding is, as mentioned earlier, a very large number of microorganisms which have been thought to be associated with Noma, which clearly is unlikely to be the case, and we still today don't have a clear idea which microorganism is causing Noma, and probably there is not necessarily one but multiple organisms that can be provoking Noma. Third, the risk factors associated with Noma, we found a very large number of risk factors. For the majority of them, they are associated with poverty, they are associated with immunosuppression, which led to the condition that will facilitate the development of Noma. One of the key findings, in addition, that we found in the review of the literature is that when a patient managed to arrive in a care facility and receive a broad-spectrum antibiotic therapy, then the likelihood that this patient will die is relatively low. And in this review, we found that only 10% of the patient died. That doesn't tell us that this is the real mortality of Noma, because most probably the majority of the patients dying don't reach hospital. It does demonstrate that if you could detect Noma, so train healthcare workers to recognize Noma and treat them very early, at a very early stage, then you would probably prevent massively the mortality associated with the disease and the sequelae that require surgical intervention if not aesthetic intervention, to be able simply to close the wound, be able to speak again, and to breathe normally with reconstruction. And often these kind of interventions are extremely complicated and are extremely costly.